AMD is certainly a disease that gets more prevalent as we get older. We try to, again, diagnose it as early as possible because the earlier we can diagnose AMD, the more positive outcomes we have long term.
Hello everyone, and welcome to Visionary Voices in Optometry, a series from the Ontario Association of Optometrists focused on real conversations about vision and eye health. Today, we're talking about age-related macular degeneration, which is a leading cause of vision loss. What makes it especially concerning is that it often develops slowly, and in the early stages, there may be no obvious warning signs. I'm Mark Donison, and I'm joined today by Dr. Wes McCann, a practicing optometrist and valued OAO member.
Hello, Dr. McCann. Thank you so much for joining us today.
Thanks so much, Mark.
It's great to have you here. We're going to talk about a serious eye condition today, but before we get to that, tell us a little bit about yourself and how did you get into optometry?
So I got into optometry because I always wanted to do something in the medical field, and medicine's always been an interest to me. And then how you practice medicine is very different in a hospital setting versus in private practice. I knew I didn't want to do a family doctor route. I didn't want to do the hospital route, so explored different health professions that would intrigue me. And when I came across optometry, you get all the benefits of getting to see patients every day, developing those relationships over the years. But you really get a keen interest in medicine with the eye specifically. And the eye is the window to the soul, but also the window to the rest of the body. And you get to help people and diagnose and manage things that show up in the rest of the body that come through the eye as well. So it was a really interesting field to get into and have enjoyed it in my career so far.
For those who may not be familiar, what is age-related macular degeneration and how does it affect vision?
Yeah, so age-related macular degeneration, let's break it down with its name. So it's an age-related disease. So as we get older, the risk factor of having it gets higher and higher. And it gets progressively worse over time. So it is a progressive disease. And what it does is it affects the macula, which is that high density area in the back of the eye at the central part of the back of the eye, where we have all of our centralized vision. So all our HD centralized vision. So wherever we're looking, you're using your macula to see with. And what happens over time is that area of the macula starts to degenerate. And through a pathological process, it starts to create these little bumps in the retina that start to occur that creates this distortion for patients. And over time, it can develop into a more advanced dry form or advanced wet form where it takes away the vision more significantly over time. So the analogy I like to use is think of dry macular degeneration as a carpet on the floor. And when you're young, that carpet's nice and flat. Over time, you start to get these little deposits of sand that start to form underneath the carpet and creates these bumps that form on the carpet. And then over time, that deposit of sand can start to wear out the floor underneath, and then those pipes that are underneath can start to leak through the cracks that's created and grow. In AMD, you're growing new blood vessels into the cracks, but you leak this fluid that starts to destroy everything that's on the carpet. So, if you leave fluid long enough, in a flooded basement, it starts to destroy things. Same kind of idea with wet macular degeneration. So in wet macular degeneration, we send those patients to get injections to dry up that fluid. And the quicker we get to that, the less disease or less damage occurs in that area.
Can you share with us your experience in managing patients with AMD? So we'll call it AMD. It'll be a lot easier to keep
Much
going.
easier, yes.
But your experience in treating patients
with AMD, absolutely. Yeah. So AMD is certainly a disease that gets more prevalent as we get older. So as we get older, we look for it more. We try to, again, diagnose it as early as possible because the earlier we can diagnose AMD, the more positive outcomes we have long term. So we start doing additional testing to identify AMD earlier in that pathology process to be able to step in earlier and be able to slow that process down as early as possible.
Is it possible for somebody to have AMD without realizing it?
Absolutely. So AMD in the earliest stages, we call a subclinical form of AMD. And in glaucoma is a different disease, but we tend to see structural changes occur first, and then we see functional changes occur. In AMD, we more start to see functional changes occur, and then we see structural changes later. But those functional changes that occur early in AMD are difficult because the average patient doesn't really notice them. They're pretty subclinical at that stage. So it might be going from a bright outside to a dimmer inside becomes a little bit more challenging over time, but it's such a gradual process. So From day 1 to day 2, you're not going to see an acute change or a quick change, but it's a slow process that starts to change over time. So if the average person is watching out for it, it's really difficult to detect. So we use technology to help us detect early stages, that subclinical stage, as well as structural changes down the road.
Are there any risk factors that increase someone's likelihood of developing AMD?
Well, there's modifiable and non-modifiable risk factors that exist. So our modifiable risk factors are ones that we can change. Non-modifiable are ones that we can't. So age certainly is one non-modifiable risk factor. I wish we could do something about that and slow that down,
right?
but we can't.
Yeah.
So as we get older, age certainly plays a role. So once you hit 60, 1 in 8 have AMD. At 75, 1 in 3. So that drastically goes up as we get older. Another non-modifiable risk factor is our ethnicity. So those of European descent can have a higher risk factor of developing AMD than those, say, of African descent. And then lastly, genetics play a big role as well. So for genetics, if you have a family history, that increases your risk factor of getting AMD. So those that have an immediate relative with AMD, your risk factor goes up by 2 to 4 times. So that significantly can increase your risk as well. So those are all things we can't really change. Things that we can change, smoking. So being a smoker increases your risk about 4 times of developing AMD in your lifetime. Diet, or more particularly how it relates to pigment density in the back of the eye. So we have something called macular pigment density in the back of the eye. And as we get a lower macular pigment density over time, or our diet doesn't contribute to the carotenoids that we ingest that help to build up that pigment density, if that's low, again, it increases your risk factor by about 4 times. So diet. The next one that's a modifiable risk factor, sun exposure, can certainly cause an elevated risk of AMD. So that's something we want to watch for. And then obesity is another one. So the larger or the higher our BMI, the more risk we are of developing AMD in our lifetime as well.
What are we seeing in terms of trends, or with an aging population as an example? Are we seeing more of this condition come?
Absolutely. So with the aging population that we do have, that risk factor of age specifically being that non-modifiable risk factor, we're seeing more and more AMD show up in our practice because we have older patients that are showing up more frequently as well.
You said earlier on that the condition often starts with few or no symptoms. And so a regular eye exam would pick that up. But for those who don't have regular eye exams, what would someone see or feel early on in terms of the symptoms?
Yeah, so early on, again, unless you're really attuned to looking out for things, you're not going to have any symptoms and you're not going to notice anything changing. So again, getting that diagnosis early is really key in terms of prolonging how long you have good vision. But if you, say, didn't get an eye exam, what would you notice early? Dark adaptation is probably the earliest change that you'll start to notice. So coming from a bright outside to an inside where it's a little bit darker takes a bit for you to adapt to that change. Okay. So that would be an early stage. But most people don't start to recognize symptoms of AMD until that intermediate to late stage. So they already have these large drusenoid deposits, these byproducts, metabolic byproducts that are building up underneath the retina, those sand under the carpet analogy I gave. And when that's starting to build up there, that's when people start to notice it. But we're already at this, not subclinical, not early, but intermediate stage of AMD, well on your way to advanced. So you're much later in that disease process when you'll actually, the majority of the population starts to see visual changes.
Right. So what equipment is used to diagnose this condition? Because you were pointing sort of inside the eye, right? And so the equipment that is used to diagnose the condition, what does that equipment let you see? And then how much does it cost you to buy that type of equipment?
Number one, dark adaptation is one we use early. And what it does is you get a headset that gets put on. And what that headset does is it blocks all the external light. And then it flashes you with a stimulus and it sees how long does it take for you to recover from that stimulus. And that has an over 90% specificity and sensitivity, which means very accurate in determining early stages of AMD. So what we can do with that is we can start to see inside the eye the functional component of how well is it, or how well can you adapt and change to those changing light conditions. So that would be one technology we use in that very early stage of AMD. Later on, we start to use things to manage that structural change over time. So retinal photography is one, OCT angiography. Those are other technologies that we use to help to look at the inside of the eye. So when we use our direct ophthalmoscope, which is used as a mainstay tool many years ago, you only have this tiny little hole that you're looking through, the pupil, and you have this tiny little light source that you're looking, and you have to try to search for everything. So older school, we don't tend to use that for AMD anymore. Slit lamp would be another one, which most people that have had an eye exam are probably familiar with, and the fact that you put your head in it and there's a light that shines in when you're sitting in the exam chair. But again, it's only a small slit that's looking into the back of the eye, and you're only getting a small view and you're moving that around in the back of the eye to see. You don't really see elevation as well with that as you would with other more advanced technologies. So a retinal photo is great in the fact that it could take a picture of the whole posterior segment of the eye, kind of like a panoramic view of the back of the eye, and you can quantify much better the amount of drusen that's building up in the back of the eye. So the analogy I give is, let's say that you were coming over today and you looked up the sky and you said, tell me about the clouds in the sky. And I would say, it's a cloudy day. It's pretty cloudy. And then next year you come in and you tell me about the sky and the clouds in the sky. For me to quantitatively tell you the difference between this year and next year of how cloudy today was versus a year from now is really difficult. So a picture allows us to take a look at all of that in the back and look side by side to see how much is it changing. So that helps us to give a really good quantitative analysis of the surface layer. Now, where an OCT or OCT angiography comes in is that not only are you getting a surface view of that, but you're getting a 3D view of not only the surface, but all the layers underneath. So when I describe that disease being the carpet and the sand underneath the carpet, I can now see how high is that sand, how confluent or how much is that sand clumping together underneath, and then also are the pipes underneath starting to leak into that retina at all before I start to see major visual changes.
Right.
So when I start to see that 3D view on OCT, that gives me a big value. And then OCT angiography is even more advanced in the fact that it maps out all of the pipe infrastructure underneath, and you can see where all those pipes are underneath, within, and I can see, are any of those pipes growing, or are they multiplying, or are they changing underneath the surface? And then I can identify risk of that changing later on. So all these different technologies are beneficial in different ways for us to identify where are you in the disease process, how likely are you to convert into a more advanced stage next, and where is it that I need to focus more attention on, or do I need to see you more frequently to catch that disease as early as possible? Or what does this disease look like for you in particular as a person?
The extent to which you invest, and so what does that look like for you as a
hundreds and thousands of dollars to again take the best care of our patients. We want this equipment that we can identify disease early so we can get the best outcomes. And investing in that equipment is really important for us because we want those best outcomes for patients, but it is a big burden to the practice as well.
Let's keep digging into the concept here, and with AMD. So when it's detected, what happens next? Yeah, so
when we detect an early subclinical stage, or let's say an early stage of AMD, there's a lot of literature out there that supports getting them on an AREDS or AREDS-like formula that's going to help to slow down that progression. Now, nutraceuticals is a difficult topic because there's so much variety on the market. CTV did an expose a number of years ago about the number of nutraceuticals that exist on the market in terms of the macular supplements that don't meet label claims. There's different studies that support certain ones do better than others. So it's a very complex market to navigate as a patient, which can be difficult. So making sure that you're getting those regular eye exams and taking the advice of your optometrist as to what nutraceuticals you should be on that's going to be evidence-based and that's going to be able to slow down that disease as much as possible. So there are certain supplements we'll get our patients on early that have shown to be able to slow down the progression of AMD by 27%. So again, if we detect you now, and let's say you have a 15-year path of AMD, let's say 20-year path of AMD, I could maybe save 5 years of that vision because we started so early and we were able to slow that down, that 27% over that period of 20 years. So identifying it earlier, getting them on that nutraceutical early. And again, there's in-office treatments that can help to improve outcomes in terms of what the person's vision or quality of vision is as well. So some peer-reviewed literature on being able to slow down that, or be able to recover some of that vision change that's occurred as well when you're in that intermediate stage. So there are different treatments from a vitamin standpoint and an in-office treatment standpoint. And there's light-based therapy ones that are coming to Canada that are well-researched that are going to help us in that journey as well for patients. But there are things that we can do to improve visual quality for a patient or slow things down with a nutraceutical route.
Right. For patients diagnosed with early-stage AMD, are there steps that can slow the progression or protect the remaining vision?
Yeah, so one of the risk factors we had mentioned earlier was that low macular pigment density concern. So if you have a low macular pigment density, your elevated risk of getting macular degeneration is about 4 times in your lifetime. So let's say you have a family history of AMD, you're concerned, you get checked out, we test your macular pigment density and it's low. You could take a carotenoid supplement and again, take a look at the literature on them. But some supplements have been able to show that you can improve or increase that pigment density in the back of the eye, which again, when linked to that low pigment density, can reduce your risk of getting it down the road. And in those early subclinical stages, that would be what we recommend. Literature supports that once you have an intermediate stage of AMD, that's when we would switch to that AREDS formula. So at that point, we would look at the AREDS formula, or a low zinc version of that AREDS formula would help to slow down that intermediate stage and onwards.
The well-being of patients is obviously an element that you would be dealing with too, right? When you're seeing people, and when giving people news about their vision, particularly when it's not the best of news. So how do you encourage patients to deal with such news and to help them sort of work through the reaction of hearing what's going on with their vision?
Yeah, so it can be difficult. And if a patient's coming in for the first time, and first time we're seeing them and they're coming in because they've had a visual change, that's when we have those more difficult conversations, because we could have caught that disease a lot earlier if they've been coming in for a routine exam. So those are the more challenging conversations that do certainly occur. But again, it's intervening and discussing, hey, what are our positive outcomes, positive options that we can look at, and what's our expected outcome from this as well. So those are certainly the more challenging ones. The beauty about our job is we have so many patients that come in for a regular comprehensive eye exam every year. And especially once you become a senior, you absolutely want to have an annual exam, because things start to change a lot faster. Like I mentioned, that risk of AMD is 1 in 8 at 60 and 1 in 3 at 75. So if you wait 2 years in between that, that's a significant amount of time. So an annual eye exam is super important. So when we have those patients coming in for those annual exams and they're doing the testing we're recommending based on risk factors, based on age, all of that, then we see a much earlier identification of this disease, which makes my job so much easier, because then I don't have to have those difficult conversations at that late stage. I get to have the good news story of, hey, you know what? I know you have this. 1 in 8 have it at your age, but the great news is we've caught it at such an early stage. We have so much time to slow this down. So it becomes a better news story as opposed to a bad news story when we're catching it at that early stage, which is great with the technology that we have today. We just need people to come in regularly for an eye exam. Yeah.
If there's one message you would like the viewers to take away from our conversation today, what would that be?
Get a regular eye exam and listen to the recommendations of your doctor. If they're recommending that you get certain tests done, then you should get them done. OHIP only covers so many things that are in an eye exam, and there are things beyond what OHIP covers that are really integral to the health of the eye. So ensuring that you're getting the recommended tests, because you're coming to your doctor because you trust them. And you're coming to them because you have faith in their clinical judgment and what they're telling you to do and requesting you to do. So have faith in that, budget for it, and get your annual eye exam so that we can ensure that we get the best outcomes for our patients, and we can intervene as early as possible and manage you to the best of our ability until the end of life.
Thank you so much for sharing your knowledge, encouraging people to come out today, and it was a real pleasure. Thank you so much.
It's been a pleasure to be here.
Okay. Super. Thank you.
Thank you.
Age-related macular degeneration is serious, but with regular eye exams and early detection, there are steps patients can take to protect their vision. If you haven't had a comprehensive eye exam recently, this is your reminder. Your vision matters, and so does your long-term eye health. To learn more, visit the Ontario Association of Optometrists website and connect with a local optometrist near you. Thank you for joining us. If you enjoyed this episode, hit the like button, subscribe, share a link with your friends, and stay tuned for another Visionary Voices in Optometry. We'll see you next time.